Praptoraharjo, Ph.D. from University Center of Excellence AIDS Research Center of Atmajaya Catholic University. The second speaker is Linda Ray Bennett, Ph.D. from Nossal Institute of the University of Melbourne. And the third speaker will be Judith Levy, Ph.D. from University of Illinois, Chicago. And this panel session will be moderated by Dr. Lisette Irarrázaval, MS, Ph.D. And the last panel of the symposium on the topic of way forward for better care, we will have another 3 great speakers. Will be joining us Dr. Rina Rajasuryar, M.Pharm, Ph.D. from University Center of Excellence in HIV/AIDS of University Malaya, Professor Pandey Putu Januraga, MCAS Dr. Ph. from Udayana University, and last but not the least, Professor Peter Rees, MD, Ph.D. from Amsterdam Institute for Global Health and Development. This panel session will be moderated by Laura Nevendorf, MPH. This event will start is already starting from 8 local Jakarta time or GMT +7. So throughout this event, should you have any queries, it can be delivered through the Q&A box provided below, and answers will be given during the discussion session facilitated by the moderator. As participants in attendance, you are also welcome to use the chat features to create and to initiate discussion among participants. Please be advised that the entire event will be recorded and broadcasted live through YouTube. And during the symposium, we will also provide interpretation feature. You can find it in the bar below and look for a globe icon. If you wish to listen to the English version, you may click English or click Japanese to hear for the Indonesian version. In general, today's event will be divided into 3 sections. This panel section, and then another poster session in the morning, in the afternoon Jakarta time, and another panel session after that. If you wish to view the previous panel sessions from day 1 and day 2 of the symposium, you may find it in YouTube and search for Pusat Penelitian HIV/AIDS Unika Atmajaya. And now, let me introduce our first moderator of the day, Dr. Lisette Irarrázaval, MS, PhD. Dr. Lisette is an assistant professor at Pontificia Universidad Católica de Chile School of Nursing. Dr. Lisette gained her Doctor of Philosophy of Public Health from University of Illinois, Chicago in 2015. Without further ado, I'm going to hand over to Dr. Lisette for the panel session. Dr. Lisette, the floor is yours.
Thank you very much. Well, I welcome everybody to good morning and good evening to some. I have the honor to be able to moderate this session. So I would like to go and introduce a little bit further Ignatius Praptoraharjo. I hope I said it well. As Caroline said, he's a senior researcher from the University Center of Excellence AIDS Research Center at Atmajaya Catholic University of Indonesia. He's a lecturer at the graduate school of Social Psychology of Health at Atmajaya, and at the Graduate School of Public Health, Surakarta State University, Solo. He has honors of Global Health Initiative Awards, School of Public Health at the UAIS, member of panel of expert commissioned by National AIDS Commission to develop the National HIV/AIDS Strategy and Action Plan 2015 to 2019. Full scholarship for attending and presenting research abstract in different conferences, international conferences. He has several publications in peer-reviewed journals regarding community responses to HIV during COVID-19 pandemic, about understanding the challenges faced in community-based outreach programs aimed at men who have sex with men in urban Indonesia. He has also written articles about syndemic and synergic effects of intimate partner violence, crystal methamphetamine, and depression in HIV sexual risk behavior among women who inject drugs in Indonesia. With no further, I would like to give Ignatius the word so he can start his presentation about HIV aging care and older transgender women, expectations and concern of later life. Please go ahead, Ignatius, you have 20 minutes for your talk.
Okay, good morning.
There you go. I can hear you well now. Go ahead.
Hi, Lisa. How are you? Good morning, everybody, and also good evening, Lisa. Thank you for this opportunity to present my presentation on HIV and older warrior in Jakarta, actually. But I would like to deliver my presentation in Bahasa, and my presentation is in English. Caroline, could you give me access to present?
Sure, Mas Gamit, sebentar. Ms. Carmen, can you please check if we can now share your screen?
Yeah, now it's working. Perfect. There you go.
Oke. Selamat pagi Bapak Ibu, saya ingin menyampaikan hasil asesmen kecil kami bersama dengan Yayasan Kebaya di Yogyakarta. Asesmen ini dilakukan sebenarnya dalam rangka untuk mempersiapkan pengembangan shelter untuk lansia dan juga mereka yang mengalami kesulitan-kesulitan untuk merawat diri khususnya dengan penyakit HIV ataupun juga penyakit-penyakit yang lain yang dikaitkan dengan masalah usia lanjut. Nah, saya ingin memulai paparan ini dengan menggambarkan tentang bagaimana kesehatan dan transgender secara umum, di mana penelitian-penelitian yang terkait dengan dampak stigma, diskriminasi, faktor-faktor sosial dan struktural yang terkait dengan layanan kesehatan, pemenuhan hak kesehatan, kemudian juga kesehatan mental dari transgender ini masih relatif sedikit dan juga sangat beragam. Dan seringkali fokusnya relatif lebih tampak pada masalah-masalah yang dominan, misalnya hanya yang terkait dengan HIV. Sementara isu-isu kesehatan lain cenderung juga terabaikan. Kemudian juga dalam berbagai macam penelitian, baik secara nasional ataupun regional, melihat bahwa transgender yang lansia cenderung memiliki risiko kesehatan fisik yang lebih buruk, kemudian mengalami disabilitas, mengalami berbagai macam gejala-gejala depresi dan juga stres yang lebih tinggi dibandingkan dengan mereka yang bukan transgender. Demikian juga secara khusus HIV juga merupakan bagian yang cukup signifikan dalam kehidupan waria ataupun male to female transgender di berbagai macam belahan dunia gitu ya. Dan khusus di Indonesia, saya kira ini juga menjadi satu posisi yang tidak proporsional dialami oleh kelompok ini terkait dengan penularan HIV. Sekitar pada pertengahan tahun 2000-an, mungkin 1 dari 3 waria yang ada di Jogja pada waktu itu diketahui HIV, dan kematian HIV pada waktu itu juga cukup tinggi. Ya, kematian yang dibagikan oleh AIDS juga cukup tinggi dialami oleh komunitas waria di sana. Dan salah satu faktor yang dominan dari penularan HIV pada kelompok waria ini adalah masalah kerja seks, ya. Dan kita tahu bahwa kerja seks itu juga dipengaruhi oleh berbagai macam faktor struktural, apakah itu kemiskinan, kemudian kewajiban mereka untuk memenuhi kebutuhan mereka sendiri maupun keluarga yang mereka miliki, kemudian pekerjaan yang tidak mudah untuk mereka peroleh karena pendidikan mereka yang rendah, dan juga berbagai macam relasi sosial yang membuat mereka mengalami situasi-situasi yang buruk. Nah, apa yang kemudian menjadi isu atau masalah di dalam asesmen kecil ini? Yang pertama adalah bagaimana pengalaman-pengalaman waria lansia dengan HIV ini memiliki perhatian atau harapan pada masa-masa hidup selanjutnya. Nah, kita ingin melihat dari sisi pengalaman transisi dalam masalah gendernya, dan juga bagaimana mereka mengalami transisi ketika memperoleh status HIV. Kemudian kita juga ingin melihat bagaimana ketika mereka mempersepsikan diri sebagai lansia, dan kemudian bagaimana memahami berbagai atau membuat atau making sense dari situasi ketidakpastian dan juga berbagai macam kemungkinan buruk yang diakibatkan oleh situasi-situasi sebagai waria, sebagai lansia, dan juga sebagai orang dengan HIV. Dan yang terakhir adalah bagaimana kita melihat harapan-harapan mereka untuk hidup mereka di masa yang akan datang. Nah, ini adalah cerita dari 4 orang waria dengan HIV yang berusia lanjut. Ada Abi, ada Bunda, ada Cinta, ada Dina. Ini adalah nama samaran saja, dan hampir semuanya berusia 60-an tahun. Asal mereka bukan dari Jogja, tapi dari luar Jawa, dan mereka datang ke Jogja dengan berbagai macam alasan. Karena memang ingin karena ingin tinggal di Jogja, kemudian karena ingin memperoleh perawatan HIV yang baik di Jogja, dan juga karena diajak teman untuk tinggal di Jogja. Nah, pekerjaan mereka cukup bervariasi, ada yang memiliki usaha kecil, ada yang sebagai pembantu rumah tangga, ada yang menjadi make up untuk artis, ya, dan juga ada yang bekerja sebagai NGO staff. Nah, rata-rata mereka sudah, ya, Bunda dan Cinta relatif lama diagnosa HIV, sementara Abi dan Dina ini relatif 5 tahun terakhir. Ya. Dan mereka melaporkan juga melakukan medical transition, khususnya menggunakan kontraseptif pills atau pil KB, kemudian juga menyuntikkan silikon cair di berbagai bagian tubuh mereka. Nah, hanya salah satu dari mereka itu yang melakukan operasi plastik, khususnya terkait dengan wajah. Mereka memulai melakukan inisiasi ART relatif bervariasi. Ada yang segera setelah mereka tahu HIV, tetapi ada juga yang menunda hingga beberapa saat, dan ini juga memberikan pengaruh terhadap mereka ketika di awal memulai ART, misalnya Bunda dan Cinta itu mengalami masalah-masalah yang cukup berat, bahkan sampai diopname beberapa kali ketika belum memulai ARV. Sementara Dina relatif sehat, tidak pernah sampai sekarang tidak pernah mengalami kesakitan hingga saat ini. Tapi keempat-empatnya ini sehat, ya, sehat, dan kemudian mereka bisa bekerja seperti biasa. Kehidupan seksual mereka tetap aktif semua, ya, jadi mereka masih ada yang masih menjajakan seks, walaupun itu tidak rutin, tetapi juga ada yang membeli seks, ya, ketika dia merasa tidak cukup percaya diri kalau dia akan memperoleh tamu ketika menjajakan seksnya. Rencana masa depan, teman-teman waria ini ada yang berkeinginan untuk pulang, tetapi yang lain memutuskan untuk tinggal di Jogja karena berbagai macam alasan. Utamanya alasan yang dipakai adalah bahwa mereka memiliki dukungan sosial yang baik dan memiliki organisasi waria yang memang cukup membantu. Mereka bisa melakukan kegiatan religius karena ada pondok pesantrennya, mereka punya kegiatan seni karena mereka ada Ikatan Waria Yogyakarta, dan juga mereka bisa memperoleh dukungan layanan kesehatan karena ada yayasan kebaya. Itu yang membuat mereka merasa nyaman di Jogja. Nah, ketika kita melihat bagaimana transisi gender mereka, kita melihat bahwa pengalaman waria mungkin tidak seperti pengalaman heteroseksual, ya, atau berdasarkan norma-norma heteroseks yang ada sekarang ini, karena kita bisa melihat bahwa perjalanan mereka untuk menemukan identitas gendernya cukup bervariasi. Ada yang harus dipukuli, harus diobatin, gitu ya. Tetapi mereka tetap merasa bahwa inilah yang kemudian menjadi identitasku. Tapi ada juga yang seperti tidak peduli mau jadi perempuan atau mau jadi laki-laki atau mau jadi seperti laki-laki atau perempuan, itu bukan menjadi masalah. Tetapi bahwa secara umum dari keempat ini hanya satu keluarga yang relatif tidak memberikan sanksi kepada waria ini ketika mereka menunjukkan identitas gendernya. Nah, di dalam proses gender transisi ini kita juga melihat bahwa ada isu yang seringkali muncul berulang adalah isu tentang bahwa waria itu harus cantik. Nah, ada beberapa yang kemudian memberikan definisi tentang bagaimana waria itu cantik ketika dia bekerja di tempat yang diketahui sebagai tempat untuk nongkrong di kota-kota, misalnya di Jakarta, misalnya di Taman Lawang. Ya, ketika belum berada di sana berarti belum menjadi waria cantik, karena memang ada struktur tanda kutip kekuasaan gitu ya yang ada di sana yang kemudian membolehkan siapa boleh nongkrong di sana atau tidak. Demikian juga waria juga merasa bahwa ya waria itu selalu cantik gitu ya, dan mencoba untuk selalu tetap cantik. Demikian juga mencoba untuk selalu merasa muda. Nah, sehingga berbagai macam upaya-upaya coba mereka lakukan, seperti melakukan transisi secara medis, ya, khususnya pil KB, membesarkan payudara, menghaluskan kulit, atau mungkin juga menonjolkan kekuatan-kekuatan di bagian-bagian tubuhnya. Nah, sehingga silikon itu seringkali disuntikkan walaupun dilakukan oleh teman-teman mereka sendiri. Dan satu catatan yang muncul dari teman-teman ini adalah bahwa ketika waria muda itu masih cantik, seharusnya mereka itu berpikir tentang kemampuan-kemampuan yang lain, karena kalau tidak, maka akan terjadi seperti sekarang ini, di mana sebagian besar waria karena tidak memiliki keterampilan akhirnya menjadi pengamen. Nah, transisi gender yang dialami atau yang dilakukan oleh waria ini mungkin bisa menggambarkan tentang live event, hal-hal yang kejadian-kejadian yang penting di dalam hidupnya dibanding dari perjalanan kronologis mereka. Jadi misalnya dia merasa yakin sebagai waria setelah pergi ke berbagai macam tempat, kemudian merasa bahwa saya itu waria benar ketika mereka memperoleh pasangan laki-laki, ketika nongkrong di jalan pada waktu yang masih sangat muda, atau mungkin juga sudah melakukan hubungan seks ketika masih SD, gitu ya. Itu menjadi sesuatu hal yang menjadi penanda bagaimana mereka itu melihat bahwa oh, saya ini waria. Tetapi pada akhirnya, gitu ya, pada akhirnya teman-teman ini kemudian merasa bahwa saat ini mereka relatif mantap dengan identitas mereka sebagai waria, tidak mencoba untuk merasa menjadi laki-laki atau tidak mencoba untuk merasa jadi perempuan, ya, karena ya mereka merasa bahwa ini yang ada di dalam mereka ya bukan laki-laki, bukan perempuan, ya waria. Nah, ini yang kemudian keyakinan seperti ini tampak dari 4 waria, ya. Jadi tidak proses untuk mempercantik, proses untuk menjadi yang lain itu kemudian tidak terjadi saat ini. Ya, hampir semuanya sudah menghentikan penggunaan hormon atau mencoba untuk mengubahkan rasa. Ya, ini hidup saya tinggal sebentar, untuk apa saya melakukan hal-hal yang mungkin tidak penting ini. Nah, bagi mereka ketika diketahui HIV positif, maka ada 2 hal yang kemudian mereka ceritakan, bahwa mereka mengalami situasi yang mungkin tidak masalah ketika diketahui sebagai diketahui HIV positif, misalnya seperti Abby atau Dina, dia merasa bahwa ya ketika HIV ya mungkin nggak masalah karena saya selama ini sudah mendampingi teman-teman ODA sebelumnya, sehingga dan teman-teman ya dalam konteks di Jogja cukup banyak teman-teman waria yang HIV, sehingga mereka yang merawat sebagai teman walaupun tidak terikat dalam pekerjaan sebagai staf LSM atau pendamping. Ya, tetapi karena pengetahuan mereka tentang HIV membuat mereka ketika terinfeksi ya tahu apa yang harus dia lakukan. Kemudian yang kedua itu adalah ketika HIV walaupun terlambat mereka memperoleh informasi, sebenarnya kalau di Jogja banyak temannya dan juga ada LSM yang bisa membantu mereka untuk bisa merawat penyakitnya. Oleh karena itu beberapa orang tadi si Cinta dan si Bunda itu pindah ke Jogja karena dalam rangka untuk memperoleh dukungan dari teman-teman dan komunitas atas penyakit yang mereka alami. Dan mereka ketika datang ke Jogja dengan situasi yang cukup parah dan sekarang sudah dengan dukungan teman-temannya sudah bisa produktif kembali. Nah, ini yang menarik adalah ketika kita membicarakan bagaimana posisi mereka sebagai orang lansia, mereka cenderung menjadi sangat normatif, ya, mencoba untuk menyesuaikan dengan harapan masyarakat sebagai orang tua itu seperti apa, sehingga mereka cenderung lebih mampu merasa membawa diri, ya, apa yang boleh, apa yang tidak boleh, bagaimana berinteraksi dengan masyarakat umum dan seterusnya relatif lebih tertata dibandingkan ketika masih muda. Mereka tidak bergaya-gayaan di depan publik dan seterusnya, dan mereka cenderung lebih lebih kalem ketika mereka ini, termasuk juga berdandannya. Demikian juga ketika melihat hidup mereka merasa bahwa hidup mereka relatif lebih stabil daripada hidup mereka ketika masih muda, dan mereka melihat bahwa ya hidup sekarang ini ya relatif lebih sejahtera daripada yang lain karena saya bisa menerima saya apa adanya. Nah, walaupun kita melihat bahwa apa adanya itu ya dalam situasi yang keterbatasan. Nah, ada beberapa hal yang kemudian menjadi perhatian concern dari waria lansia ini adalah bahwa keberlangsungan dari ARV itu apakah ada atau tidak, karena mereka juga tidak yakin. Siapa tahu nanti tidak boleh, karena ada pengalaman dulu kita memperoleh dukungan dari pemerintah daerah, tapi ternyata pemerintah daerah menghentikan sehingga beberapa obat yang terkait dengan HIV itu itu tidak bisa dipenuhi, sehingga mereka harus membayar sendiri. Kemudian meskipun cukup toleran masyarakat, tetapi bahwa mereka juga tidak ingin status HIV-nya itu diketahui. Menjadi lebih khawatir lagi ketika mereka waria, ya, status mereka sebagai waria, sudah waria, HIV dan lansia lagi, itu juga jadi kekhawatiran tersendiri. Yang lain adalah kekhawatiran untuk tidak memiliki pasangan seks, ya, karena walaupun dengan cara yang berbeda-beda mereka melakukan aktivitas seks, tetapi mereka merasa bahwa memiliki pasangan seks itu tetap sebagai sebuah bagian untuk menunjukkan kewariaannya. Kemudian yang lain adalah mengalami penyakit-penyakit yang lain, dan mereka concern karena gaya hidup mereka sebelumnya seperti apa, sehingga kemudian khawatir kalau ada penyakit-penyakit penyerta selain penyakit HIV yang mereka alami ini. Dan pengalaman dari teman-teman waria yang lain itu juga semakin membuat mereka menjadi lebih khawatir terkait dengan penyakit itu. Dan yang secara sosial adalah walaupun mereka sudah ada teman yang bisa diandalkan, tapi seringkali mereka merasa bahwa tidak enak untuk menggantungkan pada teman, karena bagaimanapun juga mereka hanya teman, tidak bisa seperti keluarga yang mampu untuk itu. Tapi ironisnya adalah bahwa keluarganya tidak peduli dengan mereka. Kemudian ketidakpastian yang lain adalah memperoleh pendapatan, apalagi dalam situasi yang seperti ini, COVID seperti ini, kemudian juga musim hujan, ya mereka nggak bisa ngamen, kemudian mereka untuk bisa menjajakan seks juga semakin sulit, kecuali melalui online. Harapannya adalah pada umumnya mereka itu menggantungkan pada pemerintah dan komunitas untuk bisa mendukung mereka kehidupan yang lain, dan salah satu yang muncul adalah adanya shelter bagi mereka, sehingga mereka kemudian bisa memastikan diri, bisa dijaga oleh teman-temannya. Sementara pemerintah diharapkan juga terus memberikan bantuan kepada mereka. Walaupun sedikit, Dinas Sosial sampai sekarang juga masih mensupport secara terus-menerus teman-teman dengan HIV untuk jaminan hidup keseharian. Ya, walaupun itu dalam jumlah yang terbatas, tapi kemudian bisa digunakan untuk bersama, sehingga itu bisa menghidupi cukup banyak teman-teman ODA yang ada di shelter itu. Yang lain itu bagaimana pemerintah kemudian juga bisa memasukkan mereka ke dalam program-program jaminan sosial, sehingga ya karena mereka merasa bahwa tidak punya penghasilan yang tetap, kadang-kadang punya, kadang-kadang tidak, sehingga bagaimana mereka bisa hidup tentu saja sangat bergantung oleh pemerintah. Bantuan tunai itu menjadi satu harapan yang besar bagi mereka untuk bisa mereka peroleh. Dan kita secara umum ya tidak nyaman kecuali satu, Abi merasa nyaman dengan keluarga sudah menerima semua, sehingga dia ingin pulang ke kotanya dan bisa dirawat oleh keluarga. Tapi yang tiga merasa bahwa ya tidak ada gunanya menggantungkan diri pada keluarga dan lebih menggantungkan pada dukungan dari teman-teman. Nah, sebagai kesimpulan bahwa ini gambaran yang diperoleh dari asesmen itu agak berbeda dengan gambaran yang diperoleh dari studi-studi sebelumnya, barangkali karena ini informannya hanya sedikit dan mereka cukup berpengetahuan tentang penyakit HIV dan sekitarnya, sehingga mungkin ini bisa menggambarkan positif situasi yang lebih positif daripada studi-studi sebelumnya, baik dalam akses kesehatan ataupun juga dari dukungan sosial ataupun dukungan psikologisnya. Yang jelas bahwa mereka saat ini merasa lebih mantap dengan gender identity-nya, meskipun mereka punya pengalaman transisi yang berbeda, kemudian menjadi HIV positif bisa diantisipasi kalau memiliki pengetahuan yang baik tentang HIV dan kemudian bisa memperoleh dukungan dari teman-teman atau komunitas, dan sebagai orang tua ya cenderung menjadi lebih konservatif, menjadi lebih sesuai dengan harapan masyarakat. Kemudian kekhawatiran mereka yang utama adalah kehidupan mereka keseharian. Apakah mereka bisa makan, apakah mereka bisa merokok, mereka bisa memperoleh pasangan dan lain sebagainya. Sementara untuk kesehatan mereka merasa bahwa ya itu saya patuh saja minum obat dan tidak memikirkan itu sebagai sebuah masalah yang berat bagi saya, karena itu akan membuat saya stres. Dan pemerintah dan komunitas itu merupakan dukungan utama mereka untuk bisa menghadapi ketidakpastian yang ada di masa depan. Saya kira itu dari saya. Waktu saya kembalikan kepada Lisa. Terima kasih.
Thank you very much, Ignacio. A very interesting presentation. Please remember to post your questions on the chat or question and answer available for you to write, and we will approach those questions in the discussion. So thank you very much again. And I will introduce our next panelist, Linda Bennett. And while she is Associate Professor, Head of Education and Learning, Nossal Institute for Global Health, Melbourne, School of Population and Global Health at the University of Melbourne. She has won several prizes, one Gungwu Prize for the Best Article, edited volume accolade from the International Convention of Asia Scholar. In 2015, the Ruth Benedict Prize for the Most Outstanding Edited Volume with the International Association for Queer Anthropologists for Sex and Sexuality in Contemporary Indonesia. And while she has several publications also in peer-reviewed journals related to reproductive desire and disappointments, about contestations of gender, sexuality, and morality in contemporary Indonesia, and further other studies. We are pleased to allow Linda to be able to share her talk today with us. And Linda, just for you to know that I will let you know when you have 10 minutes left of your presentation through chat. So please go ahead.
Thank you. Thanks very much, Lizette, and thank you to the Panitia and all of the participants. Forgive me if I speak in English. It's a lot easier for me than Indonesian. Could I please have my slide stack up? Just waiting for the slides to come up. The presentation was sent through yesterday.
Carolyn, she is probably having a
technical problem. Okay, well, I'm going to talk about stigma and discrimination, and I'm going to discuss this in the context of case studies of cervical cancer among women who are HIV positive in Indonesia. Cancers are a huge issue for people who are HIV positive, and rising incidence of cancer is also a huge issue for people aging in Indonesia. So the intersections of these two things are something that we're really going to have to deal with moving forward. So I wanted to take this case study to look at how stigma and discrimination act as barriers to healthy aging by looking at the intersections of cervical cancer discrimination and also HIV discrimination. So next slide, please. Okay, so I was just saying, just iterated the purpose of the paper. My approach is a case study approach and also a life course approach. So it's taking a biographical lens on health that considers aging as a long-term process, not aging in terms of an age group. So really understanding that as a process and how everything that comes in your life will impact on how successfully or unsuccessfully you age. I'm also taking an intersectional approach, so looking at how different forms of stigma and discrimination intersect and are layered to have higher impacts on the health of particular people. And I'm taking a gendered approach because, as we know, gender and heteronormativity are very important in shaping people's health and in shaping people's and medical practitioners' responses to health. I'm not going to talk a lot about methodology because I really want to concentrate on the insights that stem from the data, but just briefly, I'm a medical anthropologist, and this data comes from 31 case studies that we developed with women from March 2020 to January 21. We collected, for each woman, we collected a life history and illness narratives about the different illnesses that they'd encountered, in-depth interviews, participant observations, field diaries. We also had a lot of interaction over WhatsApp because women would just kind of remember something they want to say or reach out for support. And that ended up being a very, very rich form of data. And it was also very good for us to fact check and make sure that women were remaining in contact with the support organisations that were available to help them through their illness. So next slide, please. I just want to touch on a few definitions of stigma and discrimination. And I know definitions are also very culturally distinct, but these are the definitions I'm going to use in this talk. So we have enacted stigma, which is about what people do to other people. And it refers to differential treatment, unfair treatment, exclusion. It's also sometimes referred to in the literature as external stigma or discrimination. Then we have felt stigma, which is also extremely important and refers to what happens for an individual who is stigmatised. It refers to those feelings of shame, the expectation that they're going to be discriminated against, and it prevents people from seeking help and accessing care. It's also referred to sometimes as internal stigma or self-stigmatisation. And one of the things I'd really like to point out is there's been so many really important insights shared so far in this conference about multidisciplinary teams, about upscaling the resources available, about getting, better access to the care people need. But fundamentally, if people experience enacted and felt stigma, they won't access the services. So no matter how many resources you pour into the services, if you don't work at the other end to make people feel safe, you're not actually improving the problem. Another form of stigma that's very, very salient in the Indonesian context is moral stigma. And that's when a person's moral identity, their moral subjectivity is denigrated on the basis of their social identity or their health status. Moral stigma is also directed at people close to a person. So it can be a person's children, it can be a person's partner, it can be a person's friends. So it's sometimes referred to as stigma by association as well. And finally, just touching on the concepts of layered and intersectional stigma, which have been used interchangeably in the HIV literature. And they refer to how all these different forms of stigmatised identities come together within a single person or within a group of people. And this framework is often used to explain the combined effects of stigma on health and wellbeing. So let's get into the data now. Next slide, please. I'd like you to meet Amina, who's age 53 and was one of our participants. Her name has been changed, of course. Amina identifies as a heterosexual woman, as a widow, as a mother, and as a devout Muslim. She was born and raised 2.5 hours north of Jogja. Her family were farm labourers working on a tobacco plantation, and she completed junior high school and then needed to leave because of financial hardship. She was first married when she was 16. She's been married twice and widowed once. And she feels stigmatised as both a widow and as a HIV-positive person. Amina is the younger of 2 siblings, but has no contact with her brother, who ended their relationship after discovering she was HIV-positive. She has 4 children. 2 are adults and live independently, and 2 are still completing high school. Her younger children live with relatives because she can't support them financially. So she's very isolated in terms of family connections. Amina also has no income. She's never worked in the formal sector. She owns no form of transport. She owns no mobile phone. And her parents' home was inherited by her brother due to adat, and she has no access to inheritance. So subsequently, when I met Amina, she was sleeping in a cafe storeroom on the floor as payment for cleaning the cafe. So no cash payment, but she was allowed to sleep there. She later moved to a free cancer hostel while she was undergoing treatment for cervical cancer. So Amina discovered her HIV status after her husband's death 10 years ago, and she's tried ARV therapy intermittently, but had trouble managing the side effects, and she didn't feel supported by the Puskesmas staff in a regional area. She hasn't connected with any HIV support groups because they're highly visible in regional areas. They aren't able to disguise their presence like in large cities that are cosmopolitan and have a lot of difference. And she was worried that if she's seen associating with people from a support group, everyone will know her status. So when I first interviewed Amina, her mental health was very poor. She was suffering from severe depression and suicidal thoughts. She was suffering from both the effects of her cancer as well as treatment side effects. She'd paused her ARV therapy because she felt unable to handle the combination of different treatments, and she'd received no advice from her oncologist regarding her treatment, HIV treatment during cancer treatment. So at age 53, Amira was struggling with cervical cancer and is what would be described in biomedical terms as a non-compliant patient. She was impoverished, homeless, and socially isolated from both her family and other possible sources of social support. So it's obvious that these circumstances cannot support the achievement of healthy ageing. And this panel is about the social aspects of healthy ageing. So now I want to share with you some words from Amina. You've heard about me. This is the case study that we've consolidated from spending over a year with Amina. Let's have a look at how she feels about her life. So next slide, please. I'm going to read the quotes in Indonesian, but there are also translations in English. Hopefully I'll satisfy everyone. So I asked Amina, bagaimana rasanya tinggal di rumah singa? She answered, bagus karena gratis, tapi aku merasa sendirian. Ibu-ibu lain di rumah singa tidak bergaul. Mungkin mereka udah sadar aku tidak biasa. Rasanya malu sekali. Mungkin mereka tahu karena kelakuan perawat yang menjauhkan diri dari saya di klinik onko. So you can see that the stigma was having an ongoing impact both on her treatment experiences and her social isolation at her accommodation. She felt different, tidak biasa. So again, I asked her, how are your children? Are you getting time with your family? Bagaimana kabar anak-anak ibu? Apakah dapat membagi waktu bersama keluarga akhir-akhir ini? She replied, aku kangen mereka sekali. Anak yang udah besar, dia mampu dan bisa bantu sedikit. Tapi yang masih sekolah, kasihan mereka. Aku suruh pergi ke sekolah dari rumah tante. Aku tidak bisa hidupin mereka dan tidak mau yang perempuan direndahkan karena ibunya sakit HIV dan kanker. Tidak mau mereka menderita karena aku. So this is really quite heartbreaking. She separated herself from her female children to protect them from moral stigma. So again, her care of others, her concern for others is making her more isolated. We can have the next slide, please. So this just two more quotes from Amina, because I think it's really important to hear the voices of the people that we're working with and talking about, and not just taking for granted what stigma means and how it impacts. So I've asked her about her cancer treatment experience. Bagaimana pengobatan kanker berjalan? Bagaimana perasaan ibu tentang proses ini? And she answered, kadang-kadang saya tidak tahu apakah saya bisa melanjutkan pengobatan ini. Saya mungkin tidak tahan. Saya tidak tahu apa akibatnya bagi HIV. Saya merasa lebih sakit dan lebih lemah. Sampai kupikir kalau Tuhan mau, ya sudah cukup. So this is just really hard to hear, but I think really important that we hear that, without support, people are driven to the point where, they can't see the point of going on. They don't see the point of life without support and going through these incredible health challenges. And that the burden of the treatment is not just physical, it's psychological. And finally, I asked about whether she was getting help from the cancer foundations or the HIV polyclinic, because there are institutions designated to support people, and I wanted to know whether she was connected to them. Apakah ibu menerima dukungan dari yayasan kanker atau poliklinik? And she replied, HIV tidak tertarik dengan hal kanker dan hanya suruh memakai obat terus. Tapi obat dua-duanya kuat sekali dan aku takut minum begitu banyak. Apalagi puskesmas cukup jauh dari rumah singa. Aku tidak kuat jalan dan mahal sama ojek. So again, she's just not getting the support she needs to navigate these health challenges. She feels alone, even though there are designated institutions to support her. And there's a lack of service integration. The people who are offering HIV care are only trained in a very narrow area. They're not given the skills and support that they need to help someone get through cancer and the side effects and the additional cancer needs. Obviously, in a resource poor time due to COVID and in a health system that isn't highly resourced, we're a long way away from the kinds of multidisciplinary health centres where everything's under one roof, like was being described in the Netherlands or might be available in Australia. But at the same time, service integration and dedicated caseworkers can improve the situation. So next slide, please. So now I'm just going to give a quick analysis of how all these different disadvantages were intersecting for Amina to influence her health. So she had stigma associated with her marital relationship. Thank you. She had stigma associated with her HIV status from oncology nurses, residents at the Rumasinga, peer patients, and her own brother. She had internalisation HIV stigma, and she distanced herself from HIV community support. She had felt stigma associated with her cancer diagnosis, because at diagnosis, it's emphasised that women who get cervical cancer are promiscuous, which is outrageous. And there was also moral stigma, fear of her stigma being transferred to her children. So the result was intersectional stigma as a woman who was widowed, who is HIV positive and has cervical cancer diagnosis. And alongside the stigma is also disadvantage. And we know that the social determinants of health require you to have a permanent home, require you to have an income, require you to have access to integrated healthcare, and require you to have access to health insurance. I'm not quite sure if we can see the slide there regarding health insurance, but for many people who come from regional areas to access HIV or cancer care in cities, they don't have the appropriate local identity. And many people who are HIV positive don't have a legal identity. And this is also a huge barrier to accessing care. And it's a form of discrimination. It's a form of separating people from their rights as citizens. Next slide, please. Okay, so this slide is a word cloud that I generated to include all of the different forms of discrimination that have been reported to me over the duration of time that I've worked with people who are HIV positive, just to show how complex it is, and because lists are boring. And the point I wanted to make is that it is complex, and different types of discrimination are experienced by different people, but they also link up so that they're experienced over the whole life course and not just from the point of diagnosis onwards. Next slide, please. So I'm coming to the end. Now I just want to connect, these really difficult experiences of discrimination with the social determinants of healthy ageing. There are probably hundreds of social determinants of healthy ageing that we could put together in very fancy diagrams, but I've chosen 6 that, really emphasize to me as important in the research that I've recently conducted and what women have said that they need in order to be healthy. And this is, of course, access to safe quality healthcare. They need property. They need transport to get to care. They need a mobile phone to make appointments. They need a home. You can't be well without a home, a safe home. They need social engagement and belonging. They want health literacy. They want to be educated. They want to understand their health conditions and they want to understand how to be healthy. And they want financial security, which, really aligns well with what Bennet was reporting in his paper. So without these core determinants, healthy ageing is just not possible, and stigma and discrimination acts as major barriers to reaching these determinants. Next, please. Thank you. So I just want to touch on a few priorities that I think we need to address in order to remove stigma and discrimination as barriers for healthy ageing. And there are many priorities. I've just included 4. First, guaranteeing stigma-free, safe health services. And we can achieve that through training for all healthcare workers, through monitoring of healthcare worker practices, through involvement of people with HIV in training and monitoring, and also through certification of health services and stigma and discrimination. If they have to be certified for patient safety and infrastructure safety and a whole lot of other things, there's no reasons why they can't be certified for stigma and discrimination training. The second priority is guaranteeing comprehensive health services for people living with HIV. So as they age, their health needs become more complicated. There are so many areas in which they need additional health support. So, these include mental health, cancers, diabetes, heart disease, liver disease, and for many people living with HIV in Indonesia who have low incomes, anemia. And I think they need dedicated case managers who can support the management of complex medications, prevent polypharmacy and manage toxicity. So there's kind of super duper all-in-one health institutions are not within our reach, probably within the next 5 years because of COVID and because of resource constraints. But having dedicated case managers who understand the complexity of what people are facing is a really great short-term solution. The second priority is increased support to counter accumulated impacts of discrimination and stigma and discrimination. So to acknowledge that these impacts have been built up over time. So there needs to be programs to promote financial security, to promote social belonging, and to improve access to long-term care, which is essential for healthy ageing. And finally, legal reforms and enforcement of laws, which is going to go on for a very long time, but it's a really important part of the picture. The rights for all to a legal identity need to be recognised, and there's been really successful advocacy around that during COVID-19 among trans Puan in Jakarta. There needs to be prosecution for those enacting stigma and discrimination, so that the laws need to be used, not just changed, but actually applied. There needs to be removal of legal barriers to marriage and recognition of partner rights, as people living with HIV often need a lot of support when they're ill, and their partners, friends, communities, the people who support them need to be recognised as legal guardians or as having legal power of attorney. And finally, very long-term project is the decriminalisation of sex work in directing drug use and homosexuality. So while society at large sees these activities as criminal activities, we're not going to get the widespread changes we need in terms of stigma and discrimination. So I have one final slide. So just to wrap up, the points I really wanted to share today were that experiences of stigma and discrimination for people living with HIV have a cumulative impact on their health and wellbeing over the whole life course. We need to consider how healthy ageing is determined by experiences in early life, not just from the age of 50 onwards. We need to recognise that stigma and discrimination are not just something unfortunate. They're structural barriers to achieving the social determinants of healthy ageing. If we view healthy ageing as a social process, then we can address these structural barriers. We need to not simply see it as a biomedical challenge. Because stigma and discrimination are systemic and widespread, eliminating them is going to require systemic and widespread interventions, not one-off band-aids. We need programs that are scalable across the nation. And finally, people living with HIV should be involved in these interventions to eliminate stigma and discrimination. It should provide jobs for them. It should provide a voice for them. They should be able to talk about how their humanity is being compromised and how their health is being compromised. But it's absolutely essential that we recognise the process of combating stigma and discrimination as a society-wide responsibility. It can't be something left as a marginalised ghetto space for people living with HIV to address alone. So they need to be involved but not held entirely responsible for these processes. Thank you so much for the opportunity. May I just have thank you. This is my acknowledgements of all the people that made this particular research possible, and thanks for the opportunity to talk about cervical cancer as a very important health issue for people living with HIV. Sudha.
Thank you very much, Linda, for this interesting presentation that allowed us to better understand this intersection, right, of the different types of stigma as a barrier to healthy aging among people living with HIV. And you have helped us to take a closer look of how complex it is and how much more we need to do. But we will leave all the questions and for Linda for the discussion part. So please write down your questions. And I will introduce to our final panelist that unfortunately cannot join us today, but she has left her presentation through a video. It's Judith Levy, and she will talk about the intersection of HIV and aging. She's Associate Professor Emerita of the University of Illinois School of Public Health, the Director for the UAIS AJCUI Training Program in Advanced Research Method and Translational Research. She has several research going on, and for us, it's a pleasure to be able to hear her talk through this video. Please, Caroline, or go ahead.
Hello, everyone. I'm Judith Levy from the University of Illinois at Chicago, and I'm sorry that I can't be there in person today for the forum, but it is Thanksgiving holiday, actually Thanksgiving Day here in the US. We call it Turkey Day because we do a lot of feasting and we get together as families. It's a time for us to really share what we've been doing, see people we haven't seen in a while, show photos, talk about where we're going, where we've been, do a bit of gossiping about those who aren't around. So it's a special time and it's my favorite holiday, and there's no way I can miss it, and my family would never forgive me. But I am very honored to have been asked to participate in the forum by Zoom, and I'd like to thank Evie Sukhmaningram for having helped me with this presentation. I have a number of things I'd like to share with you, so let's begin. Today, I'm going to talk about the intersections of HIV and aging. Today's presentation will talk about the graying of the AIDS epidemic globally, why people are over 50 are at risk, older key populations at risk, living well and healthy with HIV, and also strategies and programs to help facilitate healthy aging with HIV. I'll be drawing on my own research on HIV and aging that began in Chicago back in the 1980s. At that time, the AIDS epidemic had just broken out and was beginning to be a topic that people were looking at and understanding and worrying about and trying to put programs into place, but nobody thought about anyone over age 50. But as we did our community outreach and started to talk about drug users and their HIV risk, we found that there were a great many older adults. And as people began to look at their clinic records, they found there were a great many older adults. But at the time I started, nobody thought they were out there, with the exception of about 5 or 6 of us. And our research goes back to that. And then we're very glad to see that it has built over time. I'm going to draw on that and also what I know about HIV and aging from the scientific literature. Clearly, and this has been one of the topics of the forum, is the number of people who are over age 50 with HIV is increasing. Globally, it's estimated that nearly 6 million people over age 50 are living with HIV, and that this number has nearly tripled since the year 2000. Why? Well, for one reason, the world's population is growing older. Here in Indonesia, I know that it originally started with a population pyramid with more young people than old, but slowly you're seeing a squaring of the epidemic, as demographic people like to talk about it. And then this allows for a number of older people to be around and to get HIV, unfortunately. Also, more older people than in the past are tested and subsequently diagnosed. There may have been a lot of them out there, but we don't know because they weren't being tested. Also, modern life presents many new risk opportunities. And as we begin to take on lives that have many new opportunities for leisure, for excitement, for getting together, for engaging in all kinds of activities, some of these have risk attached to them. Also, as we all know, successful ARV treatment, fortunately, has now led to longer lives. This slide shows the proportion of people with HIV/AIDS over 50 by region. And if you look here, we still see that Eastern Europe and Central Asia are in there, but their rates are growing. But the greatest number is in the Western and Central Europe and North America. But look what's happening with Asia, America, and the Pacific. It's growing very rapidly, and toward the end, it is actually the fastest growing epidemic among people age 50 than of all the different regions. Here we see the number of people with HIV/AIDS age 50 in low middle income countries plus high income countries, and we can compare them. And this really allows us to see how rapidly, these are our low middle income countries, it's increasing. So while we tend to think of high income countries as having the highest AIDS epidemic and also Africa, when we get down to looking at, well, where is it happening in people age 50 and older, it's really the largest number, because of the large number of people often in countries, is in the low and middle income countries. Now, we should remember that some people contract HIV during late adulthood, and others mature into late adulthood having already contracted the virus. So why are people over age 50 at HIV risk? Well, for the same reasons as younger people. And let's focus on 2 major transmission routes, sex and drug use. Beginning with sex, we now know, and there's a lot of data on this to show, that sexual activity continues throughout life, including into old age. So this means that people who are over 50 have a chance to become infected through sex if they don't practice safer sex. But we also have to realize that aging brings physiological changes that places older people at risk. Women who've gone through menopause tend to experience a thinning of the vaginal walls and dryness within the vaginal area that makes it more difficult to have intercourse and can lead to some kinds of abrasion or tearing. This can allow the virus to enter more easily and to penetrate the mucosal membrane than with younger women. Men tend to have a reduction in penile myotonia, which means they may not want to use a condom because it's a choice between having sex or wearing a condom if they can't do both. Also, the use of Viagra and other enhancement drugs has opened up new opportunities for aging men to engage in sex. The second major transmission route we're going to talk about is heroin injection. And It can happen in two ways. One, through early onset. And we used to think that there were no older drug users who were injecting drugs, as I mentioned earlier, but we found that was a surprise that they were out there. It's one of the things that we learned from the AIDS epidemic is that there are older injectors. Then we have what we call late onset users, and often this can be linked to purchasing sex. In Chicago, we saw in many of our public housing areas that men who bought men who purchased sex from sex workers, often the sex worker would introduce them to drugs. And then over time, the drugs became more important than the sex, and the sex worker became the conduit to get them the drugs. So there was a change in relationship. Also, older substance use users used as inhibiting drugs, which are psychotropic, and we see an increase in alcohol use, which can lead to riskier sex because of its disinhibiting effects. Turning to key populations among older adults, and we'll look at 4, MSM, which are driving much of our epidemic worldwide, drug users, sex workers, and prisoners, because we often forget about those prisoners, yet they are at high risk too. The LGBT community is aging. In the US, there are more than 3 million GLBT Americans who are over age 55 or 65 rather. 8,000 to 10,000 will reach 65 every day until 2030. So that's an increasing number year by year. More than 1 out of 10 will have of same-sex partners have someone who includes a partner over age 65. So older adults are well represented in the GLBT community and also at risk. I don't know about Indonesia and Southeast Asia. I wish we were having an interactive presentation so you could tell me what you know about it, but it's an area that we really should be looking at or understanding as well. We do know that compared to younger men, some of the risk for older MSM is because they're older and of an older generation, they may not be out in the open, they may be closeted. And so this ends up with riskier sex if they had to do it in less safe venues or in ways that do not permit them to do safer sex. We also find that older men report that they find protective anal sex less pleasurable than do younger men. And so they may forego the condom for pleasurable reasons. They have a higher likelihood of sexual dysfunction, which again, we've talked about, can lead to non-condom use. And they are more likely to trade off having safe sex for a partner advantage. In other words, some MSM find that they find partners very easily in the world exchange or the local exchange, but others find more difficulty because they're older and they say, all right, I'll engage in unsafe sex as a trade-off for the fact that maybe you wouldn't have otherwise been interested in me. Turning to male and female older sex workers, and again, we don't know much about them, and a lot of these older adults who are at risk we don't know much about, and that's fodder for future research, but we do know that financial need may keep them locked into the life even as they age. They tend to have less power, just as older MSM do, to demand safer sex. They're more likely to be working the streets, which is more dangerous than safer venues. And in our Chicago studies, we found many older women in their 60s actively selling sex. And it wasn't seen as a problem to them. They had found ways to get around some of the dysfunctions of growing older or physical difficulties. I don't know about the men. We didn't think at that time to study men who were selling sex to find out if how they might have changed or what their experiences were. Turning to people who use drugs, this includes older members of the general population who decide to experiment with drugs in old age. And this is certainly something that happens. Just to disclose in my own family, as well as in the literature, my grandfather at age 69 decided he wanted to try marijuana. This was before it was legal. And he tried it once and decided he didn't like it. And that was the end of that. But there are many older members of the general population who do just experiment in drugs, could be at risk during this period, or go on to be drug users. In terms of our Chicago studies, we found that older injectors tended to inject in smaller, regular buddy circles. This had a protective effect if they stayed in their circle and no one had HIV, so there was no HIV to circulate. But it could be a real risk if one of them stepped outside the circle and brought HIV in, which meant that since they seldom shared safe equipment and cleaned their needles or were using anything that would protect themselves, then that meant the virus could spread through that circle. We also found that their lives as drug users changed, that as they got older, they were recruited to run messages, to package drugs as a way to support their use. So this embedded them within the network of substance abusers and traffickers. And they often substitute alcohol for heroin or other drugs in old age, which from the standpoint of acquiring the virus through drug use was a plus, but then they turned to alcohol, which was a disinhibitor, so that put them back into the risk category. Turning to prison inmates, our often forgotten group, the US has the highest incarceration rate in the world. That's no secret, and it's also nothing that we're proud of. Inmates over age 50 constitute the fastest increasing group in the United States. And we think that by the year 2030, about 1/3 of our prisoners will be 55 years of age or older. I tried to find out something about older Indonesian inmates and couldn't find anything online. And again, maybe those in the who are at the forum know more about this. And I don't know how much to trust the World Prison Brief, but according to it, in 2020, there were 256,000 persons, roughly, who were incarcerated. We don't know how many are older than 50. And in the US, we had over 2 million persons. And again, we'll go back to the fact that they are growing, older adults are a growing population within this prison population. For prison inmates, HIV risk continues even after release. They're often re-entering into an unfamiliar society. If they've been incarcerated for 20 or 25 years, it's very different when you come out. Life has changed a lot in a couple of decades. They also have challenges in reintegrating into the family or the marital unit that might serve as a social support for them in managing HIV risk or in managing HIV if they've contracted it. Families can be angry, wives can be unforgiving. On the other hand, we also found that in many cases, they did absorb them into the family, although it might have been awkward in some ways. Older prison inmates have a high likelihood of being unemployable or having no other source of income. And in the United States, we all retire on Social Security, but inmates have never earned Social Security, or at least not enough to survive. And it's very difficult to find an employer who's willing to gamble on somebody who has a prison background. Some will turn to resuming drug use. Many will have multiple physical and psychiatric illnesses. And if you're a prison inmate and you've lived in that environment for a number of years, you have a very high likelihood to be accelerating in your aging. They age faster, and this has been well documented in the physiological literature and also mental literature. So, all right, we've talked about risk. What about people who have HIV? What do we want to look at with them? I'm going to focus on 2 essential keys to aging well with HIV. There are others, but we'll just look at 2. And of course, one of the big ones is to live a healthy lifestyle. We know that HIV disease complications, when we want to prevent them, it's better not to have them than to try to reverse their effects later. And some of the ways to do this is, and I'm sure you've talked about this in earlier days, is to avoid obesity, eat a healthy diet to boost immune response, prevent disability and cognitive decline through physical exercise, and to avoid substance abuse or to get drug treatment if needed. The second major way to live well and healthy is to adhere to ARV treatment, and it's essential. We know that physical declines can complicate good adherence, however, so anyone who is working with someone who is over age 50 or 60 or 70 needs to take that into account, that there may be physical difficulties in good adherence. We need programs that actually help them to be able to adhere better, if that's the case. Some older adults lack the social support that they need. And this I found very interesting, and it isn't only in one study, that when compared to younger people, older adults tend to have higher adherence rates. They also tend to be better able to cope with HIV due to life experience. This is something they see. I've lived a long time. I know how to get over adversity. I can cope with this disease. What are some of the ways to help and support HIV-positive adults to live well and healthy? Since this is the focus of our forum, let's look at some of these. One is we really need to expand our curriculum in social service and medical training that will increase provider awareness of HIV among HIV-positive adults. People who become providers and have not been trained to look for it don't think to look for it. And so we need to up our training activities within universities and other places where providers are trained to tell them what to look for and how to look for it. Also, they need to have some instructions on how to talk to and counsel older adults, how to differentiate between HIV symptoms and age-related disorders. And that's very difficult because many of the diseases and disorders of aging share the same symptoms as that of HIV. So it's hard to tease out which is it, the aging or the HIV that needs treatment. It's important for our providers to learn how to coordinate with other clinicians to treat other problems, because as you get into an increasingly older group, they're going to have more cases of morbidity or illness than the younger group typically, and clinicians need to know how to balance this and to work together toward it. And also they need to recognize and avoid negative, what we'll call drug-to-drug interactions. The University of Illinois, and I'm sure we're not alone in this, has a unit, a special unit where older adults go to be taken off of their drugs that have been prescribed to them for different reasons. And it's because one doctor gives them this, another doctor gives them that, and then together they're pretty soon having a whole list of drugs, some of which may have anti-drug interactions. So that in this particular unit, they take them down and then start building up slowly. But this seems to be an area that really gets neglected in medical school for older adults and needs more attention. All right, we also need to tailor our HIV education for older adults that addresses the biological and social changes of aging, helps people recognize and reduce their risk. And risk behavior is very interesting for risk assessment for older adults. When you ask, or when we asked some of our older adults in our Chicago studies about being at risk, they didn't see it the same way as young people. Instead, they would say something like, well, I've been using drugs for the last 30 years and nothing happened to me, so I must be immune. Or, I'm 80 years old, and we did have some 80-year-old people. I'm 80 years old, what am I worrying about? By the time HIV would get me, I'm going to be gone anyway. I'm going to do what I want to do. So we really don't know much about how older people assess their risk, but we need to at least educate them to help them recognize and reduce it and to know the facts that they need to know to do their own self-assessments. We also need to make sure that our prevention materials and posters, media messages are targeted and show older adults. And if we have, and I suspect we do, providers in the forum audience, take a look at your posters, take a look at your materials and see if any of them have older people on them. If not, make sure you have some. Also, we need to offer training and education settings where older adults congregate. One of our projects, we actually went to senior centers in the US and we held videos and we did various educational programmings there. It was sometimes interesting because some of the adults in the audience would come up and say, well, I'm not at risk, but I see you have a basket of condoms over there. Could I take a bunch for my grandchild or my grandchildren? So I don't know whether they were using them for themselves or for their grandchildren, but in either way, they were aware of risk and aware of HIV, and this had promoted their ability to perhaps protect themselves, perhaps protect others. All right, we might also consider offering possible pharmaceutical assistance. Vaginal gels can help to mitigate against tearing of the vaginal area. Testosterone for men can help to replace some of the functionings that may have been lost, so they're being more inclined to use condoms. The performance enhancement drugs for men can enhance condom use, but you need to have education for their safer use. Another thing we could do in terms of programming is to facilitate or offer online or telephone-based support groups for HIV-positive older adults. And this can be done either online and create little cadres of support groups, can be done in person. I've held support groups for older adults that have come in, and they chose what they wanted to do, and they did reading, they discussed some of the problems of being older, they discussed HIV, and often HIV prevention or HIV treatment was embedded in their larger lives as part of this discussion. Because people who are HIV positive may be alienated or at stress with their families or their partners, we should offer counseling sessions that can help both sides cope with HIV in their loved one. We also need and could offer age-appropriate exercise programs. Strength and balance building is an important one. Tai Chi is very smooth and elegant to do, and yet a good way for older adults to develop physiological strength and physiological agility without straining themselves. My local senior center offers armchair yoga. And when you go by the window, you can see about 20 people doing yoga while they sit in their chairs. And these are for very fragile or people who can't otherwise be able to do regular exercising. Another way to facilitate making sure that older adults either understand about HIV, can prevent acquiring the virus, or have better treatment outcomes and adherence are through videos or even music on HIV and aging that captures audience attention. I did a lot of research in Malawi, Africa, and there they sing. That's one of the most effective ways that they can transmit ideas and information about HIV. And they make music up on the spot, and then they share it back and forth and sing together. I know that music is very important in Indonesia and many Asian countries. So encouraging some way to use music and that love of music, or to use videos, and I know that Atmajaya Catholic University has a good video lab, is another way to get at delivering information that is needed, delivering support that is needed to people who are HIV positive and over 50. All right, so again, I would stress to create media and community campaigns that especially target HIV/AIDS-related stigma as well. Dr. Irwanto and his colleagues have talked about intersectional stigma. Intersectional stigma is when somebody belongs to two categories of people, of populations that are stigmatized. We could say that about people who are over 50 who acquire HIV. They are stigmatized by HIV, and they are stigmatized by being older at times. So the two come together to make a whole new generation, a genesis of new problems related to stigma that really need to be addressed. although it's put in here at a little bit of a subtopic, actually I meant to say that cell phone and other interventions can be designed to support and enhance ARV adherence. I have a colleague here at the university who has developed an avatar, and it looks just like the person, or they can choose somebody that they admire, and the avatar on their phone reminds them to take their medication or go to the doctor or to do this or that would really increase their health and help them to live healthy lives. And then finally, we need age-tailored community outreach services. And I know that this is something that is practiced widely throughout Asia and especially in Indonesia. But are the services age-tailored, or is the community outreach services generic without really taking into account that people over age 50 may have special needs? All right, so in summary, preventing and living with HIV at any age is challenging. Older adults confront special problems inherent in the biological, physical, and psychosocial changes of growing older. Nonetheless, older adults can and do enjoy long and healthy lives, even with HIV. And there's our HIV aging ribbon, silver for older adults, and terima kasih. Thank you for inviting me to speak. I only wish I could have been there in person to hear all the rest of the presentations, but best wishes to you for the rest of the conference, and happy Thanksgiving Day to you from Chicago. Every day of our lives are days to be thankful for. And I'm thankful for being invited to be a part of this conference. Goodbye, everyone.
Goodbye, Judith. Thank you so much for this presentation, and especially because it clearly stated and showed us how the risk factors for acquiring HIV intersects with the difficulties to achieve a healthy life among older adults, especially living with HIV, since we have a biological and social change of aging that needs to be taken in consideration. So with that said, we are going to now go to the discussion part that will allow us to review all the questions that you have posted. So I will have to ask for some help to Caroline to help me translate some of the questions, since they have been written in a different language that I managed. I would be able to read in English, but not in other language. So please, Caroline, if you can help me translate the first question that are posted, I will thank you.
Okay, no problem. So the first one is from Handayani. Handayani is thanking Mr. Ignatius for the presentation. It is interesting and she learned a lot. It was mentioned earlier that many trans women are increasingly meeting social expectations. Does this have something to do with internalizing heteronormativity, or is it a way of coping with ongoing stigma and discrimination? That was the first question.
That would be Ignatius who would please answer the question, and maybe Linda, if she wants to add something, that's perfectly fine too.
Okay.
Baik. Terima kasih Bu Handayani. Satu hal yang kita lihat bahwa ada proses normalisasi dalam kehidupan waria pada masa tua. Jadi misalnya ketika mereka keseharian, barangkali mereka kemudian tidak menggambarkan atau mengekspresikan diri seperti waria pada usia yang muda. Lebih banyak mereka misalnya berpakaian biasa, kemudian tidak menunjukkan dandanan yang menunjukkan bahwa dia waria, berpakaian juga berpakaian seperti pada umumnya. Juga mereka merasa lebih mampu untuk berinteraksi dan bisa memahami orang lain, sehingga mereka bisa mengatur hidupnya mereka itu sama seperti orang yang lain. Nah, saya setuju juga bahwa ini seperti menormalisasi norma sosial yang ada di sekitar mereka. Tapi di balik itu, di balik perilaku mereka yang kelihatan konformasi dengan perilaku masyarakat secara umum, ada keyakinan mereka bahwa menjadi waria itu adalah sebuah keputusan. Saya tidak ingin jadi perempuan, saya tidak ingin jadi laki-laki, tetapi saya adalah waria. Nah, saya kira itu yang barangkali kita juga bisa melihat itu pada level yang berbeda. Bagaimana mereka berinteraksi dengan orang, penerimaan mereka terhadap orang lain menjadi lebih besar, tetapi pada sisi yang lain penerimaan diri terhadap mereka itu juga lebih besar. Jadi tidak mencoba untuk menyesuaikan identitas mereka dengan identitas yang diharapkan oleh masyarakat, tetapi mereka yakin, tetapi mereka bisa berinteraksi dengan orang lain dengan lebih baik. Saya kira itu yang menurut saya kenapa mereka itu menjadi lebih konformis ya daripada masa-masa sebelumnya. Itu saya kira, Bu Handayani, terima kasih.
Thank you for the question. I don't know if, please, Linda, feel free to add whenever you feel appropriate. But could we go ahead with the second question, or do you would like to add something, Linda? No?
I'm in agreement that it's very much part of a person's evolving identity as they age.
Thank you. So, Caroline, maybe the second question posted.
Okay, the second question is, do ARV affect the speed of the process of PICUN is it's literally translated as memory loss for elderly PHIV. So if you have any information on that.
My understanding as not a medical doctor, but as someone who reads the literature, is that it can, but there is no guarantee that it will. So that is one of the possible side effects. But not everybody who takes ARV and ages will experience memory loss or cognitive decline at a faster rate than the general population. So that while there is a risk, it doesn't happen to everybody. And then also that the research shows there is a lot of difficulty understanding the interactions between different kinds of diseases and how they affect cognitive impairment, because often people are experiencing multi-morbidities and they are having other treatments. So treatment for diabetes, treatment for cancer, treatment for blood pressure. So there's also drug interactions. So sometimes it's very difficult to come out with, very clear population-based findings, because as people age, they tend to take more drugs. So I hope that's helpful as a non-medical opinion.
Thank you, Linda. And I think this third question posted is in English, so I will be able to read it. It says, "Hi all, thank you for the presentations. Mind-blowing. I noticed that the recommendations from both earlier speakers refer to the government and internal community. Just wondering, how do we engage wide public as the end of the day elder transgender, I think it says, would need to be in social setting with assumption that wider public still have stigma and discrimination towards transgender?" Maybe Ignacio and even Linda would like, if she wants to if you want to give
dulu.
your opinion.
Bu Linda, silakan Bu Linda.
Okay. I think that is a very good question. And I think it's about changing moral culture. Culture is dynamic. Culture is changing all the time. And we can't give up on hope about culture changing. And if I look at, the cultural change between people of my generation and people of my son's generation, it's actually very significant. So we can't forget about mainstream culture. But of course, we can't train people in mainstream culture the way that we can train healthcare workers or the way that, we can train professional bodies of people. But what we can do is advocate for leaders, such as political leaders, to stop making derogatory remarks. We can ask for the role models of society to take responsibility for not, for not keeping stigmatizing discourse alive. So I think we have to appeal to role models and, politicians and keep the alternative discourses of respect and human rights very, very visible. But widespread societal change, I think, is not something you can teach. I think it is something that happens slowly over time. And, we can use our institutions like schools, universities, and, get thinking, change in thinking happening over time. But Prof. Ignatius?
Thank you. There are further questions posted, and it says, Mas Gambi, you mentioned that elder transplant also using technology to earn living. I remember on yesterday's panel, it was mentioned that technology is one of obstacles. During your study, is there any support that needed regarding technology using?
Oke, thank you. Teknologi yang digunakan itu terbatas. Ya, jadi teman-teman waria lansia mencari pasangan melalui sosial media, seperti WeChat. Jadi berbagai macam kesempatan itu kemudian mereka bisa mampir ke WeChat mencari pasangan dan mereka bisa memperoleh penghasilan dari sana dan mereka ke hotel atau ke tempat-tempat yang ditentukan. Tapi itu yang familiar dengan mereka, ya, teknologi sosial media itu yang biasa mereka pakai, dan ini tentu saja juga menjadi satu hal yang menarik karena kita juga bisa memberikan sebenarnya pesan-pesan melalui jaringan-jaringan pertemanan mereka, baik itu di Facebook, di IG ataupun juga di WhatsApp group ini. Saya kira itu jadi potensi bahwa teman-teman waria lansia tidak terlalu kurang mengenal teknologi itu. Dan yang barangkali saya menambahkan pertanyaan dari menjawab pertanyaan sebelumnya, bahwa memang betul sekali bahwa pada akhirnya masyarakat itu menjadi tempat di mana waria itu tinggal. Dan kita tahu bahwa waria ini tidak seringkali memperoleh hambatan-hambatan dari masyarakat. Misalnya, untuk bisa memperoleh kartu identitas, seringkali harus memperoleh izin dari masyarakat sekitar. Bahkan, misalnya ada keluarga yang bersedia untuk menjadi tempat di mana mereka sebagai anggota keluarga, dan kemudian dari situ bisa memperoleh identitas penduduk, gitu ya, NIK atau KTP. Tetapi tantangannya adalah justru dari RT atau RW, karena itu tidak diperbolehkan. Nah, saya kira ini menjadi penting sekali bagi kita untuk tidak hanya berfokus pada komunitas, tetapi komunitas yang kemudian juga mencoba untuk melakukan hubungan-hubungan yang sifatnya sosial dengan masyarakat di mana mereka tinggal. Nah, di dalam konteks di Jogja misalnya dalam masa pandemi ini, salah satu cara yang kemudian digunakan untuk membangun solidaritas bersama dengan masyarakat adalah dengan membuat dapur-dapur umum di 9 titik di mana waria-waria ini tinggal di kampung-kampung itu. Nah, ini berlangsung sekitar 6 bulan dan ini juga memberikan respon yang positif bahwa waria itu ternyata juga peduli dengan lingkungannya dan juga memberikan dukungan ketika masyarakat juga punya masalah, mereka mau terlibat di dalam kerja bakti, mereka mau terlibat di dalam kegiatan sosial yang lain. Saya kira itu model-model tanda kutip sosialisasi yang cukup mengena untuk mengurangi stigma dan diskriminasi dari masyarakat. Karena stigma dan diskriminasi hanya bisa kita kurangi ketika kita bisa berinteraksi secara langsung dengan orang yang menstigma ini, karena pembiasaan menjadi penting untuk mengurangi stigma ini. Mereka takut karena mereka hanya membayangkan, tetapi mereka berhadapan dan mereka bisa bekerja bersama. Saya kira itu juga bisa mengurangi secara signifikan stigma yang negatif dari masyarakat kepada waria. Saya kira itu. Saya kembalikan.
Thank you.
Lisa.
Yes, thank you so much, Ignatius. I think because of the time, we will only have time for one last question. And what is posted here, it seems to be towards Linda. Thanks to all speakers for the insightful presentation. We knew that stigma has been a classic and complex issue, including in HIV. Is there any innovative strategy in your country that you found effective to respond to this complex problem?
Thanks for the question, and I think again it's a bit similar to my last answer, which is generational change. I think public health education, and particularly health education in schools, has had a really big impact. And for 40 years, we've had HIV positive people visiting high schools and talking about their lives and demystifying HIV and making sure that the people are not afraid of HIV. And the services now are so open. Health services now are so open and welcoming of people with HIV. So I think, it's not something that happens overnight. There are definitely important changes, but they've taken 40 years to happen. So, but I think what's going on in schools is very, very exciting. In terms of there is no sort of judgmental behaviour towards people who are HIV positive, and it's not seen as a disease that is any different to a whole range of diseases that you might be unfortunate to get in your life. So, yeah, public health promotion and health education in schools, I think, have been very effective.
Thank you, Linda. Would you say, I must ask you, would you say maybe that we could increase primary healthcare attention or prevention, primary healthcare prevention, since somehow with the primary healthcare, we would be able to reach out to the community in a better way than asking or requiring people to come to this, to hospitals or to come to the services, instead thinking of us healthcare providers reach out to the community. I see that in primary healthcare. What do you think about that?
I think a lot of interesting things have actually happened during COVID, and that health promotion in Indonesia has been taken online. It's now happening through WhatsApp, through a whole lot of seminars. So virtual outreach has been very exciting, and it's reaching a lot more people, but it's only reaching people who don't experience digital poverty. So people who don't have money for phone credit, don't have a smartphone, don't have electricity, can't participate. But that is possible. But you've got to think of everything in the COVID context. I mean, physical outreach is very dangerous right now.
Right.
And also Indonesia is a resource resource poor country in terms of the number of health workers. So I also see those opportunities for outreach as opportunities where people from HIV positive communities could be employed. They could be employed as outreach workers, and some of them are already. But, you know, you don't need a nursing degree to be an outreach worker to educate a community. So, you know, they're an unrecognised group of important professionals who would be, you know, who should be upscaled in terms of their contributions when it's safe.
Right. Thank you so much, Linda. And thank you all the panelists for this wonderful session. I know it raises a lot of questions and we would like to continue the conversation, but I know we need to hold into the schedule. And I think we have just finished on time. So I will give Carolina to be the host to be able to continue with the session that comes. And thank you all for attending, for listening, for asking this interesting question, and for the panelists again, Linda, Ignatius, and Judith Levy, for your very interesting presentation that encourage us to continue debating, continue wondering and asking how we can do better. Thank you so much.
Thank you, everyone.
Thank you, Dr. Lisette, especially for moderating and guiding this very important discussion. And it is now midnight in your time, so have a good rest after this. So yesterday we had a perspective on HIV and cognition, as well as HIV-associated neurological disorders. And it is exciting to see a deeper topic today on HIV and social aspects. We will now have a 3-hour break, I believe. We will start at 1 p.m. Jakarta time. And during the break, the break today will be shortly longer than yesterday because it is now Friday and some people need to do the prayer. So during this break, we will have 5 poster presentations. Feel free to join us during your lunch and your break. Each poster presentations will last for 10 minutes. And again, if you have any queries, you can use the Q&A box to ask for the poster presenters, and you may type your questions there, and we will help to address it to the presenters if they're not here with us. So now I would like to introduce our poster presenters of the day. We will have 5 authors. The first one is Atiti Retno Pujiati, Alessandro Alfieri, Devi Artami Susetiati, Norwestu Rusetianti, Agnia Purnawa Putri, which will be presenting on the frequencies of STI and mucocutaneous manifestations in elderly HIV patients in Yogyakarta. The second one will be Nur Aini Gigi with abstract title Policy Analysis on HIV Regulations on the province of South Sulawesi, a critical analysis on gender methodology. The third one will be Via Dolorosa Halilintar with abstract title Relationship Between Knowledge and Socio-Demographic Characteristic with Stigmatizing Behavior Towards People Living with HIV/AIDS. The fourth one is Lusa Rohmawati, Knowledge of HIV/AIDS among young adults through media leaflet, I'm proud to know. And lastly, Lalu Faris Noval Makroja with abstract title The Influence of Sasak Tribes Indigenous Knowledge in Creating a Safe Community for People Living with HIV and AIDS. So it's a wrap up for the morning or evening sessions in some of the attendees time. So, and thank you so much once again for Dr. Lisette for guiding and moderating. For all the attendants, we will see you again at 1 p.m. Jakarta time. Thank you so much. Have a great break.
morning, everyone. Thank you for giving me the opportunity to present my poster with title Frequencies of STIs and Mucocutaneous Manifestation in Elderly HIV Patient in Yogyakarta. Let me introduce myself. My name is Dr. Alessandro Alfieri. I am a resident doctor at Department Dermatology and Venereology, Faculty of Medicine, Public Health and Nursing, University of Gadjah Mada, Yogyakarta, Indonesia. First, let me start by giving you some background information about this poster. There is an increasing number of the elderly population infected with HIV in the world. This is caused by the longer life expectancy of people with HIV and AIDS taking antiretroviral therapy. It is estimated that the percentage of people living with HIV and AIDS aged 50 years and over has increased by more than 17% over the last decade. The risk factors for HIV in the elderly population are the same as in other age population, and the main source of transmission is unprotected sex, either vaginal or anal. The presence of these risk factors also increases the incidence of sexually transmitted infection in the elderly population. In addition to STIs, HIV infection is also associated with mucocutaneous manifestation. This is important because more than 90% of patients has at least one symptom in their lifetimes. There are very few studies that discuss mucocutaneous manifestation in the elderly population with HIV. This study aims to examine the frequency of STIs and mucocutaneous manifestation in elderly HIV patients. This study was conducted retrospectively using secondary data. Demographic data of the subjects were taken from medical records at the STI outpatient clinic Dr. Sajito General Hospital, Yogyakarta from September 2017 until August 2021. Demographic data were age, gender identity, risk factors for HIV and STI, time since HIV diagnosis, ARV regimens, STI manifestation, and mucocutaneous manifestation. And the classification of the elderly is based on the regulation of the Minister of Health of the Republic of Indonesia number 25 of 2016 concerning the National Action Plan for Elderly Health in 2016 until 2019, which divides into pre-elderly age 45 to 59 years old, elderly age 60 to 69 years old, advanced high-risk age more than 70 years old. Based on our finding, during 4 years, there were 123 HIV-positive elderly patients who visited the STI clinics, consisting of 92 men, 30 women, and 1 transgender. The mean age in the study was 52.70 years old and was dominated by the pre-elderly groups. As many as 80.5% of patients were taking antiretroviral in the form of tenofovir, lamivudine, and efavirenz. And the mean length of time diagnosed with HIV in the subject for the study was median of 33 months. The highest risk factor for HIV in this study were men who have sex with other men, followed by bisexuals and clients of sex workers. The most common manifestation of STI were condyloma acuminata and latent syphilis. On the other hand, for mucocutaneous manifestation, xerotic skin and pruritic papular eruption were the most common clinical symptoms. In conclusion, let me sum up my main points. This study shows that the pre-elderly groups and male sex group are at risk for HIV infection and STIs due to deviant sexual behavior that usually occurs in younger population. The frequency of STI is around 15.5%, which transmission can occur either using or not using a condom. Mucocutaneous manifestation occur in 24.39% cases. Preventive intervention is needed in the form of safe sexual behavior in preventing HIV infection and STIs in the elderly patient. Thank you for your attention.